Good afternoon, everyone, and welcome. This is going to be the start of the Bronze Sponsor Tier Vendor Hall sessions, and this session is going to be with Bronze Sponsor RQI Partners, LLC. Our speaker is going to be Julie Buckingham, who's the program manager. Her session is going to be 600 seconds to save a life, the case for public safety telecommunicators as first responders. She was unable to be here, but she did get this pre-recorded so that we are able to play it, and here it is. Thank you so much for being a sponsor. We appreciate it more than you know.
Hi everyone, and thank you for making time today to attend this session. 600 Seconds to Save a Life, the case for public safety telecommunicators as first responders. My name's Julie Buckingham, and I'm the Resuscitation Academy Program Manager at RQI Partners. The fight for public safety telecommunicators to be recognized as first responders, it's not new. We've been at this for some time now, and I'm pretty sure that I don't need to convince anyone in this session that this classification is where we belong. And while there hasn't been progress made just yet at the national level, there has been at the state and local levels. But in many of these cases, really, the only thing that's changed is the job classification title itself, and that's as far as it's gone. A title alone doesn't make us truly first responders. It doesn't help us to do our jobs better so that we can affect outcomes and save more lives. So what I want to talk to you about in this session is how we make the case to our stakeholders for public safety telecommunicators to be truly treated and represented as first responders, and with the recognition that we have a role when it comes to outcomes. And I'm going to talk to you about it in the context of a response that happens almost 1,000 times a day in this country. A response where only 10% of those calls will have a patient who survives. I'm going to talk to you about it in the context of how we can impact that dismal survival number. I want to talk to you today and make the case for public safety telecommunicators as first responders and how we can save more lives in a response to cardiac arrest. To quote Gordon Graham, which I'll do a few times in this session, the overall mission of everybody in public safety is preservation of life, and the decisions we make need to be laser focused on that. So I want to start this session by talking about the problem it is that we're trying to solve and why it's so difficult in our current state of operations to save more lives. A moment ago, I gave you some statistics on the number of cardiac arrests that occur every single day in the United States and the associated survival. I want to put this number into another context, though, that we can all relate to. The number of people who will suffer a cardiac arrest each and every day in this country is the equivalent of 6 fully loaded 737 aircraft. And of those 6 aircraft, only one of those planes will have survivors. So these numbers I've given you represent patients in cardiac arrest in all rhythms. I want to look now at some data for patients who fall into what we call the Utstein subgroup. Patients in this subgroup had a bystander witness cardiac arrest and presented in a shockable rhythm. These are the patients who are most likely to survive their arrest. The CARES registry is the closest thing that we have to a national cardiac arrest registry in the United States, and CARES stands for Cardiac Arrest Registry to Enhance Survival. The data that you see here represents 165 EMS agencies across the U.S. who each had at least 150 cases. As you can see, survival is really varied across these systems. We have one system that has a survival rate of just over 66%. And at the other end of the spectrum, we have systems that only see single-digit survival. Do you know what your survival rate for cardiac arrest is in your system? As you can see by these numbers, where you live really determines whether or not you may survive your arrest. And that's not right. When you look across the systems, the average for survival is about 33%, and that number's not great. Because another way of looking at this is that 67% of these patients are not surviving their arrest. We have to do better than this. The good thing is that we can, and all we have to do is look at this data to see that it is possible. There are systems in this country showing us that it's possible. When we look at the data over time, you can see we're really just running in place. Survival may have improved in some systems, but overall, we're stagnant. Remember, this data here represents patients who had a witness collapse and are in a shockable rhythm. These are the patients we should be saving. We can't accept that this is the way that it is and this is as good as it's going to get, because it's not true. It is possible for us to save more lives. We need to not be discouraged, but encouraged that we can do more. But why is it so hard to move the needle on survival and save more lives? Cardiac arrest is a complicated condition, and there's really 3 key factors that will contribute to a patient's outcome. The first is the patient themselves, so things like comorbidities are factored in here. We also have to contend with the event itself. Where did it happen? How long was the patient down before they were found? A patient that's been down for 30 minutes, we really can't expect a positive outcome out of that event. But for a patient with a witness collapse, and especially one that is in a VF rhythm, we should be saving these patients. But that will ultimately be determined by the final key factor, and that is our system. I can't control a patient's medical history or health, nor can I control or influence where they have their arrest or how long they've been down before they were found. But I can control, or at the very least influence, what is happening in my system. So what's actually happening in our system during a response to cardiac arrest? Let's take a minute and explore that. When we talk about cardiac arrest, we're going to look at it in the terms of the first 600 seconds of the arrest and the relationship between time and survival. So in our graphic, we will represent time in 60-second increments along the x-axis of the graph. And survival will be represented along the y-axis. There's several studies which have documented the effects of bystander CPR on survival. So for the purposes of our conversation today, we will use those findings, which state that for every minute that passes between collapse and defibrillation, survival rates from witnessed VF out of hospital cardiac arrest decrease by 7 to 10% if no CPR is provided. The line across our graph will represent the decline in survival for every 60 seconds that elapses in the arrest without an intervention. For our purposes today, we'll refer to this as the slope of death. Since over 70% of arrests occur in the home, for the purposes of this scenario, we will say that this is where this incident occurred, and that it was witnessed by a family member who we will refer to as our lay rescuer. So let's start from the beginning, when the clock starts for the patient. The slope of death and the clock on survival starts at the moment of collapse of the patient. At this point, clinical death has begun and oxygenated blood is no longer circulated to the vital organs of the body. Within 10 seconds of the onset of the arrest, oxygen stores in the brain are depleted. And from this moment going forward, this patient's chance of survival will decrease by 10% for every 60 seconds that CPR is delayed. Even though the collapse was witnessed by a family member, the call to 911 is unlikely to be immediate. They will probably try to rouse the patient. There may be some confusion and panic, and all of that delays their calling for help. And depending on where the call is originating from, it may be necessary for the call to be transferred to a different center that handles EMS for that jurisdiction. This just adds to the time. Once the call lands at the ECC having jurisdiction, now we have to verify the address, so add another 30 seconds or more to the time. At this point, we're about 1 to 2 minutes into the arrest, and probably closer to the 2-minute mark. So already, this patient's chance of survival has decreased by about 20%. After we verify the address, now we begin the initial assessment or case entry process to identify if the patient is in cardiac arrest. For purposes of this conversation, we will say that the caller is compliant and that we were able to accomplish this assessment within the American Heart Association's TCPR performance standard for cardiac arrest recognition, which is 60 seconds from address acquisition. So add that time to the clock, and that's another 10% decrease in survival for this patient. Once we have a verified address and we have enough information to generate a response, field responders can be toned out. So at this point in the incident, AED-equipped responders have been dispatched. Here's our challenge, though. It's going to take time for them to get there, and how much time really depends on your system and your resources. In 2015, the federal government conducted a study that included almost 500 EMS agencies and almost 1.8 million EMS calls. What they found was that in suburban and urban areas, the response time for EMS was about 6 to 7 minutes. In rural areas, it was double that, with 10% of those calls taking almost 30 minutes for EMS to arrive. So, as EMS is en route, the clock on the first 600 seconds continues to tick, and if nothing is done for this patient, the dying process will continue. After about 4 to 5 minutes, the patient will most likely experience permanent and irreversible brain damage or biological death. If nothing is done and the patient has to wait until EMS arrives for CPR to begin, using the 6 to 7 minute response average we just spoke about, we're now about 8 minutes into the arrest, and the patient's chance of survival has dramatically decreased by about 80%. This is 480 seconds after the arrest began. The chance of this patient surviving their arrest, or surviving their arrest with a favorable cognitive outcome, at this point, it's greatly reduced. So something that's important for us to know is that CPR actually stalls the dying process. And once it's begun, we've altered that slope of death. Survival is no longer decreasing by 7 to 10% every 60 seconds. The decrease in survival is more gradual now and averages 3 to 4% for every 60 seconds from collapse to defibrillation. The challenge, though, is that EMS just cannot respond fast enough to save that patient on their own. The good news, though, is that they are actually not the first responders to be on scene with that patient, or the first with the opportunity to provide care to that patient. It's us. It's the public safety telecommunicators who are the first responders to provide care to that patient, and who are entirely responsible for patient care until it is handed over to the first field unit that arrives on scene at the patient's side. To improve survival, we have to get CPR on board much faster, and we can. By utilizing our lay rescuer on scene with the patient, we can significantly decrease the time to the first CPR compression and increase that patient's chance of survival. The challenge, though, is that even though over 12 million people a year in this country earn their CPR certification, bystanders and lay rescuers rarely initiate CPR on their own. Think back on your own experiences. How many times have you taken a call for cardiac arrest where CPR has already been started and the rescuer wasn't an off-duty firefighter or nurse or some other medical professional? In my own experience, it was pretty rare. Let's go back, though, to our CARES data, and now this time let's look at the bystander CPR rates that were reported. Here again, we see great disparity, this time in the delivery of bystander CPR. We see one system where the bystander CPR rate is over 75%, and other systems where it's below 20%, and the average is just barely over 40%. Do you happen to know what your bystander CPR rate is in your system? When we again look at this data over time, you can see this is another area where we're stagnant. There has been some modest improvement on the lower end, but everywhere else, again, we are running in place. There's actually been several research studies done on bystander CPR and the impact that telecommunicators can have And their findings across these studies is pretty consistent. I'm just going to share one of these studies with you now, and this was one of the most recent ones that was published in 2018, and it was a retrospective study that included over 2,300 patients. What they found, and this is consistent in the similar studies, is that only about 24% of the time did bystanders initiate CPR on their own. Remember, we train over 12 million people in CPR every year, and in some states, getting your CPR certification is actually a graduation requirement. But the studies show us consistently that bystanders infrequently initiate CPR on their own when it's needed. 33% of the time, no CPR was performed, and that could have been for a number of reasons, such as the caller wasn't with the patient, maybe EMS arrived on scene before CPR could be started, or it was deemed that the patient wasn't viable and CPR didn't begin. But what this study and similar studies tell us is that public safety telecommunicators can double the instances of bystander CPR and impact survival and outcomes for patients. So you can see in this study, the instances of bystander CPR almost doubled when telecommunicators were inserted into the picture. So let's go back to our slope of death. And now let's insert a telecommunicator who is not just competent, but also confident in their resuscitation skills. They're able to coach the lay rescuer to begin CPR, and they do so meeting the AHA performance standards for TCPR delivery, with the first TCPR-directed chest compression being delivered within 120 seconds of address acquisition. Now, instead of the first compression being delivered at 8 minutes into the arrest when EMS arrives, it happens in about half the time. It is now 240 seconds since the onset of the arrest, and the slope of death for this patient, it has been dramatically altered. Not only has the telecommunicator improved that patient's chance of survival, but they've given EMS something to work with when they arrive on scene. The truth is, EMS can't save a patient unless dispatch has made them savable first. The most influential responder in the first 600 seconds of a cardiac arrest and a vital link in the chain of survival is the public safety telecommunicator. Our ability to rapidly identify the arrest, get help dispatched, and coach the lay rescuer to perform high-quality CPR can determine the outcome of these incidences. Telecommunicators are the breakthrough to saving more lives. It takes a system to save a patient in cardiac arrest, but in most systems, the primary focus is on EMS and the bystanders. Our telecommunicators are often the most neglected and under-resourced link in the chain of survival, and that's what we need to change. If we hope to improve survival, we have to change the status quo. The status quo will not save more lives, and if it could, it would, and you would not see survival stagnated as it is. If we hope to have a breakthrough in survival, we have to be deliberate in how we prepare our telecommunicators to save a life. We have to start treating them and preparing them as the first responders that they are. So, now that you understand the problem that we're trying to solve, let's talk about how you can approach your stakeholders with an argument for truly empowering our telecommunicators as first responders. And let's explore some of the solutions that will help us to save more lives from out-of-hospital cardiac arrest. So who are the stakeholders in your system? A stakeholder is an individual, organization, or an entity that has an interest or benefits from what it is that you're doing. So who would that be in your system? Some examples of who stakeholders could be in your system would be groups like the public, who have the most to lose if they or someone they love suffers a cardiac arrest. Think about your councils and your boards. They have an obligation to ensure their departments and agencies are performing in a way that not only serves the community, but also limits liability exposure. Another consideration is your employees. They're the ones who are providing care to these patients. And unfortunately, they're often the ones who also carry the emotional consequences when these calls don't go well. And as I said a few moments ago, EMS can't save a patient that we haven't made savable first in dispatch. So they should have not only an interest in ensuring our telecommunicators have the resources they need as first responders to respond to these calls, but they should also be champions of your cause. So let's start crafting our plan of how we are going to make the case for public safety telecommunicators as first responders and how we can start to move that needle on survival from out-of-hospital cardiac arrest. Like we just talked about, one of the first things we need to do is identify our stakeholders. It's going to be different in every system, and I gave you some examples of just a few to consider, but really think outside the box on this one. Think about not just who they are, but try to understand what motivates them and what will get them to buy into the case that you're trying to make, that telecommunicators are first responders and that there is more that we can do to save lives from out-of-hospital cardiac arrest. Once you've identified your stakeholders, what's the case you're going to make to them? You need to tell them the story about where you are now and where it is that you're trying to get to. There was some data shared earlier in this session that makes, I think, a very compelling argument about the impact telecommunicators can have, and that's a great starting point, but let's go beyond that. Let's look at the established standards and best practices that help to guide us in developing our TCPR programs that bring impact and empower our telecommunicators. The first thing that I want to talk to you about is the NHTSA CPR Lifelinks Toolkit. Lifelinks is a national initiative that encourages local collaboration between 911 and EMS providers to improve out-of-hospital cardiac arrest survival rates by improving care in the first links in the chain of survival, specifically the delivery of early and high-quality CPR. This full toolkit, which I'll talk a little bit about in a moment, can be accessed by going to the URL that you see on your screen. All of the resources on this website are free and available for you to use. As we get into these standards and recommendations, you're going to start to see some alignment between them. And the reason why is because these are really established as best practices that have impact on performance, which ultimately impacts survival. So as we go through this, keep track for yourself. Are these things that we're doing now, or is this an area where we have an opportunity to improve? And again, this just adds to the case that you're making to your stakeholders about what more we need to do to empower our telecommunicators as first responders. So when we get into the toolkit, we're going to see a recommendation for the need for protocols that emphasize the 3 key stages of a call for cardiac arrest. The first stage is the identification of the arrest. The second is the delivery of CPR instructions to the lay rescuer. And the third is the continuous coaching to the lay rescuer in the delivery of high-quality CPR. So that's things like correct compression rate, advising about depth and recoil, and making sure that we're not interrupting CPR once it's been started. You'll also find TCPR training recommendations in the toolkit. So let's look at what these are. First, know the recommendations, and this refers to knowledge of the American Heart Association's TCPR program and performance recommendations, which is now a policy statement from the AHA. So this document lays out the vision and methods for optimizing out-of-hospital cardiac arrest outcomes. But we have to create awareness around these recommendations within our communications center and with our stakeholders. And I'm going to talk more about what is found in these recommendations in just a moment. Next, providing an opportunity to your telecommunicators to practice continuous compressions on a training mannequin for several consecutive minutes to simulate the physical challenges of performing CPR in a real call. Not only is this an important empathy exercise, but we know through studies that callers who receive continuous coaching during CPR will often feel less tired and fatigued, and that results in higher quality CPR being delivered to the patient, and that brings impact to outcomes. So let them experience what this is like for themselves. The third segment is mastery of the 3 stages of TCPR that we just spoke about. In the fourth segment, our training should include simulation of suspected out-of-hospital cardiac arrest calls. Simulation allows telecommunicators to apply their knowledge in an environment where they can safely learn from their mistakes and oversights. Mistakes are essential to the learning process, and in this environment, they can be made and corrected without real-world harm delivered to a patient. In other sectors of public safety, whether it's law enforcement, fire, or EMS, simulation, training, and practice is really embedded in their culture. But so far, it's really not in public safety communications, and that's something that we need to be better at. And finally, you cannot improve that which you do not measure. Performance measurement is essential for performance improvement. And to be effective, it should be done in a manner that is non-punitive to the telecommunicator. Building on that last segment, the toolkit also provides information on what we should be measuring during our cardiac arrest case review, or QI. Recently, I heard the great Gordon Graham make a speech, and he said something that really resonated with me. And that is, mistakes you are going to make are the mistakes you've already made. Meaning we already know where our greatest performance weaknesses are in these calls. And that is really what's addressed in this toolkit and in these recommendations. So let's look at what these are. First, avoiding delays, pauses, and interruptions in CPR. We have to work towards reducing these pauses and interruptions in the delivery of chest compressions once they have started. It takes 30 compressions to build up enough pressure in the body to start moving oxygenated blood to the vital organs of the body, including the brain and the heart. And as soon as we stop compressions, we bottom out that pressure we worked so hard to build. So this is an important performance area to address in our QI. Next, optimizing compression techniques. When we're delivering compressions, are we doing it so that the rate is correct, which is between 100 and 120 compressions per minute? Are we instructing the caller to push down at least 2 inches? And are we reminding the caller to allow the chest to fully recoil between compressions? High quality CPR saves lives. The delivery of poor quality CPR, it's devastating to outcomes, and it's a preventable harm. Are we managing the effects of airway and ventilation techniques? On calls for a patient who was in respiratory distress or arrest prior to cardiac arrest, are these patients receiving ventilations? For an overdose patient, as an example, their blood is already oxygen deprived, so compression-only CPR is not the most appropriate treatment for them. We need to ensure that ventilation instructions are provided when it's appropriate and called for, and that it's being done correctly. And finally, managing chaos. The ability to manage callers in crisis or to work through the challenges such as positioning a patient or getting them off a bed and onto the floor and onto their back. These are the most common causes of delays and delivery of low-quality CPR. But they're a solvable problem. And the tools in the CPR Lifelinks toolkit can help you build a TCPR program within your agency that can work to address these. So let's pause and take a moment and go back to our checklist and see what we can add to that as we're working to make the case to our stakeholders about empowering telecommunicators as first responders. Is your agency using EMD protocols? If they're not, they absolutely need to be doing this. It is imperative that when we receive a call for a patient in cardiac arrest, that we are providing CPR pre-arrival instructions to that caller. EMS cannot get there fast enough to save that patient. And when we don't provide those pre-arrival instructions, we're basically giving a death sentence to that patient. And it's unacceptable. As a public safety agency and as first responders, this has to be done. Are you providing initial and ongoing TCPR training to your telecommunicators? Are you providing your telecommunicators to not just practice, but master their skills in the 3 stages of TCPR that we talked about? And are you conducting quality improvement reviews on calls for cardiac arrest? A moment ago, we talked about the TCPR training recommendations found in the LifeLinks document. And one of those is knowing the American Heart Association's TCPR recommendations, which again are now the AHA policy statement. So let's go ahead and look at some of the things that we would find in that statement. You can access the full statement by going to the URL that you see on your screen right now. So these recommendations and now the policy statement is broken out into 2 areas. First are programmatic recommendations, and the second is performance recommendations. To improve survival from out-of-hospital cardiac arrest, we really have to change the approach of how we address performance. And we need to stop siloing our activities, meaning there needs to be a connection between training and QI. QI should inform our training and vice versa. And we need to make sure that we are measuring things that have impact when it comes to patient care and survival. So the theme around these recommendations is all of these things working together to ultimately improve competency, to improve outcomes. So let's look first at the programmatic recommendations. So in these recommendations, we find that there should be 3 to 4 hours of initial TCPR training around TCPR provided to all telecommunicators who may take a call for cardiac arrest. After that initial training, every year there should be at least 2 to 3 hours of ongoing training. Ideally, 100% of calls involving EMS-confirmed cardiac arrest should be reviewed. A patient in cardiac arrest is the sickest patient that you have in your system. It's the most critical EMS call that we will take. So it's worth our time and effort to review each of these calls to look for areas and ways that we can improve the quality of patient care. And really, QI is training. So every time you perform a QI review and you provide that feedback to the telecommunicator, you're providing them with a training opportunity of how they can improve the quality of care delivered to that patient the next time they encounter a call for cardiac arrest. Next, recognition for outstanding performance. In a lot of systems, there's recognition programs when a survivor is identified. But sometimes, despite our best efforts in doing everything right, people will not survive their arrest. So it's important that we expand our recognition process to include those who are meeting minimum performance recommendations, and we'll talk about those in a moment. You should be working with a designated medical director, and you should have a connection to your EMS agencies. It takes a system to save a patient in cardiac arrest, which means we need to be working together as a team as we care for this patient as they travel through the links in the chain of survival. Sharing data with your EMS agencies, and they're sharing data back. Your EMS agencies, especially if they report into the CARES registry, can also help you to identify those calls where the patient truly was in cardiac arrest, and they can provide you with outcome data as well. And finally, there needs to be a commitment, not just from leadership, but also from our telecommunicators to the TCPR process, meaning a commitment to do the training that we need to do, to conduct the QI that we need to conduct, and to work together to improve how we're caring for patients in arrest. Next, you'll find the performance recommendations. So this is providing you a baseline of how we should be performing on our calls for cardiac arrest. 95% of the calls where recognition of arrest was possible, those calls should have been recognized. And of the calls that were recognized as arrest, at least 75% of them should be receiving CPR instructions. Recognition of arrest should be occurring within 90 seconds of the start of the call, and the first TCPR-directed chest compression should be delivered to the patient within 150 seconds of the time of call. There's another resource I want to make you aware of that should be available by the end of the year. NINA is currently in the process of creating a TCPR standard, and once it's published, I think you're going to find that there will be a lot of alignment between the NHTSA CPR Lifelinks Toolkit and the AHA TCPR policy statement. And again, the reason why is because both of those documents reflect the best practices when it comes to TCPR. So let's take a moment now and let's revisit our checklist and see how this information we just reviewed changes that a little bit. So now when we're talking about initial and ongoing training, we can expand on that and specifically look at how much initial and ongoing training are we currently providing versus the 3 to 4 hours of initial training and 2 to 3 hours of ongoing training annually we should be providing. Next is our QI process. How many of our calls for cardiac arrest are we conducting a QI/QA review on? Ideally, it would be all of them. This is the sickest patient in our system. We should be looking at each and every one of these calls and treating it as a training opportunity as well. So it may be that to start off, you're not able to do 100% of your calls, but some QI is better than no QI. So even if you're able to just start with 20% of your calls and then gradually build up until you are reviewing all of them, that would be great as well. And regarding performance, there's some questions that you need to ask and some information that you need to obtain in order to paint that picture for your stakeholders about the need around preparing telecommunicators as first responders to save more lives from cardiac arrest. The first piece of information you need to obtain is how many calls for cardiac arrest is your system handling per year? And what is your bystander CPR rate? Those two pieces of information you may need to go to your EMS agencies to get. If they report into the CARES registry, it's something that they can absolutely provide to you. Next, how often are you identifying that a patient is in arrest? And how long is it taking for you to get to the point of recognition? When we've recognized the patient is in arrest, how often are we providing CPR to the patient? And how long is it taking for those compressions to be delivered? There's one last resource that I want to bring to your attention, and it's a resource that I think is so important. And that's the American Heart Association's Resuscitation Education Science Statement and Guidelines. Many of the people in this session, you have a background and really a passion for adult learning, and you recognize that the way in which we train adults needs to be different than how we train or educate children. Adults just learn differently. How we train and educate adults around resuscitation science is also different, and we need to shift how we are addressing that education. So just a few of the things that came out of this statement is this idea of mastery learning. So not doing things just until we get them right or getting a passing score, but doing these things until we can't get them wrong, that we've mastered these skills that we very infrequently use in our day-to-day operations. We talked a moment ago about simulation and how that's not really something that's currently embedded in the public safety culture. So you'll find in this statement the need to provide deliberate practice to our employees so that they can have the opportunity to master those skills. One of the other concepts that you'll find in here is this idea of spaced learning. one and done training or sending someone to training once a year or once every 2 years, it's not effective. Knowledge and skills decay too rapidly, especially for an infrequently used skill like TCPR. Instead, practicing low-dose, high-frequency learning has been demonstrated to show that when utilized, it decreases the forgetting that happens post-learning. It decreases the knowledge and skill decay that naturally occurs, again, with an infrequently used skill. So a moment ago, we talked about the recommendations around annual training for resuscitation for telecommunicators, and the recommendation was 2 to 3 hours. So in that scenario, instead of taking someone off the floor and sending them to a class once a year for 2 hours, which really is not going to be effective in improving their knowledge and skill to improve outcomes, break that training up. So maybe now we're providing quarterly training and we're doing 30 minutes every quarter instead of this bulk learning session one time once a year. One of the other concepts in here is contextual learning. So ensuring that the learning that our employees are being provided is delivered in a way that reflects how they do their job. As an example, while everyone should know how to do CPR and they should have a CPR card, sending someone to a CPR class where they're putting their hands on a mannequin, that's not how we do our job as first responders. That's not contextual to our duties and responsibilities in a call to cardiac arrest. So just making sure that we're creating an environment where the learning looks like our environment and it's providing the information that we need to know in a way in which it is applicable and reflective of how we do our work. So there's lots of great information in here. If you have a passion for education, you will love this document. So I highly encourage you look into it. I hope you leave this session today with a belief that we can do more to save lives from out-of-hospital cardiac arrest. But the status quo is not going to save those lives. The status quo is not good enough anymore. If it was, we wouldn't see such dismal survival numbers across the country. We have to start rethinking the way in which we treat our public safety telecommunicators as first responders. We need to start preparing them as first responders, meaning we provide appropriate resuscitation, education, and skills practice, that we provide contextual resuscitation credentialing, and that we take every opportunity we can, utilizing our RQI process, to look at what we're doing and identify where can we be a little bit better. It's these actions and the things that were laid out in the documents that we talked about and the best practices that are already out there. These are the things that when we do them are going to make an impact. Many of the people in this session have probably been touched personally by cardiac arrest and have lost someone that they love. We're all in a unique position here because we have the ability to affect some change in our system. So I used to tell people, go back home and do these things to help save more lives in your community. But I want you to give yourself a little bit of permission to be selfish about this one. Go back home and do the things that we talked about to improve your system. So someday when it's someone you love, or maybe it's even you who suffers a cardiac arrest, you've created a system where that person has the greatest chance of survival that they could have anywhere in the country. That's what we're working towards. We know, though, that creating programs and sustaining programs can be difficult. We're all being pulled in a million directions, and there's always some fire in the comm center to be put out, or there's a CAD upgrade that needs to happen, or what have you. Time is our most valuable commodity, and we never have enough of it. So we may go back to our agencies and be fired up about the things that we can do and the changes that we can make, but then we get distracted with competing priorities. And as a result, unfortunately, nothing will happen, or things will be started and they won't be completed. And here we are again, back to the status quo. And that's why the American Heart Association and Laerdal Medical, through RQI Partners, created the RQI for Telecommunicator program. So this is a first of its kind resuscitation, education, and credentialing program that is designed for public safety telecommunicators as first responders. In the RQI Telecommunicator program, we operationalize the things that we talked about in these calls, operationalizing the science and educational recommendations provided by the American Heart Association. We deliver resuscitation education to public safety telecommunicators that is contextual to how they do their job. We also focus on the verified competency of the telecommunicators. That means that they're able to demonstrate in an ongoing basis their continued competency around the resuscitation knowledge and resuscitation skills, knowing the things that they need to know and doing the things that they need to be able to do to improve the quality of patient care, to improve outcomes. And then we use clinical data, so data from our 911 calls, to measure the application of learning in the real-world environment and measure how we are actually caring for patients in a live call when their lives are truly on the line. And then looking at the impact that the improved resuscitation skills of our telecommunicators have across our system. How is this impacting EMS and how they are able to care for the patient once they arrive? Are we seeing improvement in ROSC rates? Are we transporting more patients? And obviously the goal is to improve the number of survivors that we have in our system. The RQI Telecommunicator program is also the source of the American Heart Association's first TCPR credential, and it's called the RQI for Telecommunicators credential. This is a profession-specific, competency-based resuscitation credential that is only available to public safety telecommunicators through this program. I would invite you to visit our website at rqipartners.com and go to our blog and take a look at just a few of the stories that we've told around the experiences of the agencies that we're working with and some of the successes that they have had as a result of being a part of this program. Death from out-of-hospital cardiac arrest, it is a preventable harm, and it's something that we need to do more about. Hopefully we've given you some ideas and information today that you can take back to your center and start to implement. And if you are interested in more information about the RQI Telecommunicator program, or if you have any questions or there's things that we can help you with, we encourage you to please reach out to us at rqit@rqipartners.com. I want to thank you for attending today's session and for hearing about a topic that is near and dear to our heart. Stay safe, and we hope to hear from you soon.
Want to thank you once again to RQI Partners LLC and Julie Buckingham, the program manager there, for putting the session together so that we would be able to put this out there either way. And again, the session was 600 seconds to save a life, the case for public safety telecommunicators as first responders. Thank you once again, and make sure to check them out on their website, the information that's here. Send them an email, and then you can check them out as well at withinthetrenches.net/conference. And supporting our sponsors supports us as well. We wouldn't be able to do this if it wasn't for them. So thank you so very much, and we'll see you in the next one.